Good afternoon, everybody, and thank you, Paul. It's been a great couple of days with everyone, so really enjoying all of the talks so far. This one is dermatology. Like Paul said, I am not a dermatologist. I'm a nurse practitioner in Denver at Colorado Blood Cancer Institute and work with all the blood cancers, but have a particular interest in our WM patients. Our objectives today, we're going to just try to get a better understanding of the disease-related complications for skin related to WM, and also understand the ones that are related to the treatments you guys are on or could be going on to. And then what do we do to help you feel better, to help minimize some of these side effects, as well as gaining some understanding about things to ask for from your healthcare professionals. So I'm not going to belabor this too much. It's been discussed quite a bit during this event the last couple of days, but the definition of WM, it is a rare, slow-growing or indolent non-Hodgkin's lymphoma. It's a combination of lymphocytes and plasma cells, which make it a lymphoplasmacytic lymphoma. So that's a cancer of the lymphatic system, which is a large part of our immune system. It combines several different organs, the lymph nodes, bone marrow, and certain solid organs as well. It affects the B cells, which then grow into our mature plasma cells. And the plasma cells are what produce our antibodies, also known as the immunoglobulins. For all of our WM patients, it is an overproduction of IgM for the large majority of people. As we heard yesterday, some people don't have an IgM, but that's very rare. And it affects slightly more men, Caucasian, and the median age is 63. So again, this has been also shown. The problem herein lies with the large IgM molecule, the 5-sided protein. So that can cause quite a few complications, whether it be skin, neuropathy, all of the things that have been discussed the last couple of days. This is what can cause things like hyperviscosity. It can cause infiltration into the skin, which we'll have several discussions about what that looks like for IgM when it infiltrates the skin. So how do our LPL cells misbehave? The lymphoma cells can cause the B symptoms, which you can see listed there are swollen lymph nodes, night sweats, low blood counts, fevers. The night sweats are not just a little bit of wetness on your neck or your armpits. It's drenching, change your clothes, change your sheets kind of things multiple times a night. And then our plasma cells are what make the IgM. So when this gets overproduced, we have the complications. As we know, hyperviscosity, neuropathy, skin infiltration, frequent infections, and many more side effects that we'll discuss some of those with the cryoglobulinemia and what those can affect. So dermatologic conditions is actually kind of rare with WM as they're disease-related. It's about 5% of patients, although I think that just even in talking to people last night at dinner or walking around, quite a few people have had some sort of a skin condition that may or may not have been aware that it was related to WM until you treat your WM and then the skin condition goes away. So definitely underdiagnosed because they can mimic so many other skin conditions. I mean, you've got rashes, you've got petechiae, got bleeding and bruising, skin that's itchy. So the list there that we'll go over all of these individually, but when the IgM infiltrates the skin, it can cause what's called cutaneous macroglobulinosis, bullous dermatosis, just LPL infiltration, chronic urticarial or Schnitzler syndrome, and then more nonspecific but related to complications of WM would be hyperviscosity, Raynaud's, purpura, or the large purple bruise-like looking spots on the skin, vasculitis, and livedo reticularis. And then outside of the disease-related complications, things, ibrutinib, zanubrutinib, we know a lot of these treatments, especially the BTK inhibitors, can cause nail cracking or brittle nails and dry skin. Some people get hair thinning or little corkscrew hair changes, skin infections. Any grade of bleeding can be up to about 50%. So the lower the number, the less severe. And you can see some of the pictures there of what we were just talking about. I mean, spontaneous bleeding in the eyes, the skin bruising, so that can be pretty common, and many of you have maybe had that. Some people after Rituxan can get psoriasis, and we'll go over that just a little bit. And then neutrophilic dermatosis, which is called sweet syndrome, and neutrophilic eccrine hidradenitis, which affects the sweat glands. So a lot of big words, but we'll kind of break this down. So I'm glad we did these after lunch instead of before, because some of the pictures are kind of gross. Disease-related, so at the top there you can see before and after more of the purpura and dark skin reactions that people can have. Some of this is from the LPL cells infiltrating the skin. And after treatment there on the top right for you guys is after treatment. The rashes can range from just a light purple brown. They can be kind of non-irritating, just they don't bother you, they don't look great, but aren't causing any symptoms. And to more of a purple plaque-like texture. The cutaneous macroglobulinosis or bullous disease is there in the bottom where you actually have skin rupture or some ulcerations that can be quite painful and disruptive to people's quality of life for sure. So when we talk about cryoglobulinemia as a complication of WM, we're talking about the protein in the blood clumping when it touches cold temperature. So like Dr. Mattis and Dr. Forsberg yesterday showed a picture of how the blood can precipitate in the tube. This can cause some complications when it can occlude vessels, it can become quite painful, and just even the cold temperatures can be bothersome. And then the purpura is, again, the dark purple bruised-looking spots on the extremities. These also can cause some pain, which is rare, but if they also occlude a vessel, then it can be painful. And then these can also be results of hyperviscosity. So we'll see people who have hyperviscosity who have quite a bit of bleeding. They've got blood, bleeding in the eyes, bloody noses. So these are all things that can be affected as a complication of the high IgM. So Raynaud's phenomenon can be related to WM. It can also stand alone. So people can have Raynaud's and not have any underlying malignancy. You can see there are just some variations of the way people's skin can look. So it occurs in cold temperatures. It's a lack of blood flow. The acrocyanosis is that bluish discoloration of the extremities, mostly the hands and feet, but it can also be people's noses, ears, and for a lot of people, it can be quite uncomfortable. Keeping warm when you're in a cold temperature, hats, gloves, hand and feet warmers. Some people are even sensitive enough that it's bothersome to even just get in the refrigerator or freezer. And then when the blood flow returns, the tissue can turn kind of bright red again as that becomes, as the circulation comes back. So another couple of things related to cryoglobulinemia. You can see the lacy looking picture there on the left. That's livedo reticularis. And it's kind of this web-like rash. It can be benign, just again, look kind of bothersome, but doesn't have to be any sensation associated with that. It can come and go. When people are starting to progress, sometimes you get the WM controlled, skin changes, whatever those are for you, get better, and then as people progress or relapse, then this is one of the first signs for people that their disease is coming back or the IgM is rising. For some people, it doesn't ever go away despite treatment. It's just kind of how the skin looks forever. And then vasculitis, so that's inflammation or narrowing, blockage of the blood vessels. And when this occurs, we can treat this in the clinic. Oftentimes we rely on our vascular colleagues if this is something that's severe, that's painful, or if people have such poor circulation because of this, they may develop ulcerations or wounds that don't heal, and then that's something that we rely on dermatology and our vascular folks to help guide us. So Schnitzler's syndrome, a little bit of a mouthful. So this is when the white blood cells or the neutrophils start to infiltrate. So this can be quite itchy, or pruritic is the word for that. It's more commonly associated, our folks, with IgM kappa versus less with our IgM lambda WM patients. And the kappa and lambda are, again, what the little light chains are that are hooked to the Y in that big molecule. Most of people have a constellation of symptoms with this. So you can have things like a fever, you can have bone or joint pain, swollen lymph nodes, worsening neuropathy. So it usually has something else in addition to feeling kind of itchy, irritated skin. It's rare, but it's also underdiagnosed. Again, so many of these rashes or skin conditions that we see, oftentimes dermatology or pathology can't determine what these are by a skin biopsy, kind of just give a blanket statement of it could be 4 or 5 different things, and then we're trying to decide amongst ourselves what exactly this could be. Or if it's symptomatic enough, do we go ahead and treat WM and see if this gets better? Treatment for this particularly is directed at treating Waldenstrom's. Usually these things get better once the WM gets treated and the IgM starts to come down. And some people don't respond and need a medication called anakinra, which is immune suppressing, and it targets interleukin-1, which then helps with improving the symptoms. So the Sweet syndrome is named after Robert Douglas Sweet. It is a clinical presentation, a pathological diagnosis, as well as laboratory findings. It often is a sudden onset, and the lesions can be kind of benign, or they can be quite tender. These people with this also do develop a fever. They can sometimes have areas outside of the skin that are affected, so it can be in the GI tract, it can be other places in other organs that are a little bit harder to determine because we can't see those with our naked eye. And when we do the lab work, we see an increased number of neutrophils, which is part of the white blood cell. To get a definitive diagnosis, we really need a skin biopsy, and that can always be done in the clinic, just a little punch biopsy. Send that to pathology for confirmation. And they'll see in the upper layers of the dermis increased neutrophils, which again is part of the white blood cell. Some people can have this without having a cancer diagnosis or WM. So people can have this from a bacterial or viral infection. Some people can develop this during pregnancy. So really determining what it is and what the cause was, because if it's WM and an infection, we want to know how to treat the appropriate cause. And treatment requires systemic steroids, so that would be like prednisone if somebody that's not contraindicated for people who are diabetic or have osteoporosis and really brittle bones. We try to minimize steroids in those conditions if we can. You can try a topical steroid, which doesn't always work because this oftentimes can be pretty widespread. Again, treating WM may be what we need to do to fix this. And for really stubborn lesions, some people end up getting a steroid injection right into the lesion. So here's the one, the eccrine hydronitis, which basically is a fancy word for your sweat glands. So this, we have sweat glands, as we know, everywhere. Most of the time, we'll see this, like in the picture, on the extremities and the trunk. But it can less commonly affect the face, the scalp. This, a lot of times, is actually associated with the treatment itself and not WM, but we can see it both ways. So usually, when you stop the offending agent, which would be chemotherapy or whatever treatment you're on that caused this, then this slowly gets better. For some people, that doesn't always do the job, so we would need to do cautiously steroids. And sometimes these things just take time to heal on their own, and just a lot of patience, which is hard for most of us. Definitively diagnosed again by a skin biopsy, so easy to do in the clinic, and then they can also have, people can also have fevers associated with this, so it can look kind of like a viral or infectious rash, which is why we want to know exactly what we're treating, because if there is an underlying infection, we of course need to treat that, which should then help the skin rash. Sorry again, some nasty pictures. So a couple other variants of the white blood cells. We've got pyoderma gangrenosum, which in picture C and D are these really painful ulcerative lesions. They are treated with steroids initially. When they get to this point where they've ruptured and have kind of become more ulcerated, some people need immune suppressing medications, something like cyclosporin. And of course, stopping the offending agent that may have caused this initial blistering lesion. So that would be, again, something that we would need to be cautious about if it's related to the WM treatment or another medication, whether it's an antibiotic that we put you on as a prophylactic medication. We would, of course, need to stop what we think caused this. And then in picture B, we've got the paniculitis, which is just a increase in the subcutaneous fat region of the skin, so white blood cell inflammation there. And this can occur 1 day to about 3 months into starting treatment. So this is sometimes drug-related. Steroids seem to be kind of the magic thing to treat everything with, and cautiously, of course. And stopping the offending agent, which is usually one of the treatments that we put you on to help get rid of this type of rash. These can be very painful. Some people do need temporary pain medication, and not always do they affect the nerves, but this can cause kind of a nerve pain. So temporarily needing something to target that, like a gabapentin or Lyrica, if the pain is severe enough. So there can be some skin changes when your WM is well controlled and treated. So these can be mostly related to treatment side effects, and this is kind of where we'll get into more of the effects of treatment that we have you guys on. This is when IgM can infiltrate, the protein infiltrate the skin, and like I said before, if somebody's disease is progressing or relapsing, when the IgM starts to target the skin, if that's one of your presenting symptoms, then oftentimes that's the first sign of relapse for those of you who have that. Always getting a biopsy if there's any question to what the skin lesions may be caused from or the rash. Is this a drug eruption? Is this an allergic reaction to a new lotion? I mean, it can vary widely. And yesterday, a couple mentions about amyloidosis in some of the talks. We always have to be mindful of other things that can be alongside WM that can cause skin lesions or to have people have different skin reactions with other plasma cell disorders. So as many of you know, the BTK inhibitors, ibrutinib, especially since it was first generation, had a lot of off-target or off-tumor, on-target side effects because it affects other growth, other blood cell receptors. So one of them is the epidermal growth factor receptor. And this one is it's mostly responsible for the development and growth of our new blood vessels. So you can see the list there that when the BTK inhibitors block BTK, it also will block the EGF receptor. And you can get some of these additional side effects, which rash, bleeding and bruising. It acts like an aspirin effect. Infections, this can be just on the skin as well as systemic infections. Atrial fibrillation, more common with ibrutinib than zanubrutinib, and high blood pressure or hypertension in the trials was about equal with ibrutinib and zanubrutinib. But overall, the side effects with zanubrutinib really improved from the first generation with ibrutinib. So we'll go over some of these treatment-related issues here. Our skin infections can vary really widely. So we all have bacteria on our skin. We've all got bacteria on every surface. So any little opportunistic infection can be a cut, and then you end up getting staph in there, which is common on all the surfaces and on our skin already. Staphylococcus aureus can be a very minor infection to severe, and this is what we oftentimes call cellulitis. This does require antibiotics, most of the time oral antibiotics. For some people, this could be a really severe infection that needs to be treated aggressively with IV antibiotics in the hospital, and not something you want to, oh, this is getting a little red. You'll see, is it streaking up your arm or your leg? That is something that needs to be aggressively treated. It can cause quite a bit of pain for people, and as it's spreading, it can be quite uncomfortable. People will have symptoms of an infection, feel achy, have a fever, kind of the typical things that you think of when you have an infection. Folliculitis is part of inflammation or infection around the hair follicle, and that does not necessarily require antibiotic treatment. For some people, if it's irritating, you can do a topical antibiotic. Some people need a topical steroid, but oftentimes this is self-limiting and resolves on its own. And then paniculitis is just always refers to, we'll talk about this in a couple of, and we had it on another slide, the subcutaneous or the adipose tissue. And this can be associated with ibrutinib, so treating the infection as well as lowering or pausing the ibrutinib or zanubrutinib if your IgM doesn't flare. Sometimes when we pause these medications and you have an IgM flare, then you can develop a higher IgM, flu-like symptoms, so that can be a little bit confusing with an infection or that we're treating, and is your IgM flaring? So we just always have to pay attention to that. At the top picture there are different locations, or the most common locations for shingles infection. People on treatment with WM and being immune compromised are at risk for herpes virus as well as zoster, which is the shingles virus. We always do recommend people getting the Shingrix or the shingles vaccine. It is not a live vaccine anymore, so most people are able to get that, and it's a 2-shot series. And it does not cover herpes simplex, but it would cover the zoster infection. And we also put people on preventative medication if they're on treatment that requires it, with acyclovir or valacyclovir, the other name being Valtrex, to prevent it. If shingles does develop, then we use the same 2 drugs and higher doses to actually treat the infection. This can be really quite painful. So people initially get that prodromal or the before effects where they'll have kind of a burning or itching sensation, here across the chest. It's usually one side or the other. It should not generally cross the midline of the body. And then the blister-like vesicles erupt. And that can be, it's along a nerve root, so it can have a lot of nerve pain. Some people, once the scabs, or once the lesions kind of scab over, the pain goes away. And for some people that aren't so lucky, it does not occur, and they do need some more aggressive interventions with gabapentin, Lyrica. We've had several people end up seeing one of our anesthesiologists to do a nerve block because the pain is just doesn't go away. And then the lower pictures there for people who develop pretty severe oral ulcers or stomatitis. This generally isn't infectious. It can be related to ibrutinib. It can be related to when your if white blood cells drop down, having neutropenia, and can really affect quality of life. I mean, any of us have one little canker sore and know how painful that can be, let alone ulcerations in your mouth like this. So pain control is a big issue, trying to keep people hydrated, nutrition. This can be require hospitalization. If it's caused by medication, of course, we want to pause that medication, may have to stop it for a period of time and then dose reduce. And I've seen some people, even on a lower dose of ibrutinib and zanubrutinib, still develop the ulcers. But then over time, the risk of this goes away. Usually occurs 4 to 16 months after starting ibrutinib, but you can see some of these over the course of the treatment. Sometimes people need some steroids to slow down some of the inflammation, or just a topical steroid rinse in the mouth to help treat this, as well as pain medication. Other things to use would be like viscous lidocaine in the mouth or on the area, and I don't know, in Denver we call it magic mouthwash or miracle mouthwash with Maalox, Benadryl, and lidocaine before meals, just so that you can continue to keep your nutrition up. So erysipelas is a different skin infection. It is different than cellulitis in that it's the strep bacteria. And cellulitis, like I said, can have streaking, kind of a broad spread of infection. This is pretty well localized, pretty well demarcated. You can see in picture A, it's pretty well walled off. It will have a round or a border that can be a little bit raised. This is treated with penicillin, unless you, of course, have an allergy to penicillin, then medications like Keflex or cephalosporin are able to treat this. Some resolve without antibiotics, although if they're as severe as these pictures are, we definitely would want somebody on systemic treatment to help to control this. And then fungal infections on treatment because of the immune suppression can be a risk. Again, getting a biopsy to try to determine these because they can kind of be nonspecific, but the antifungal medications would help to control these. And the fungal infections that we see are aspergillus, one called mucormycosis, and a non-tuberculosis mycobacterium. So if we have skin changes, oftentimes, what do? These usually occur in the first year of treatment. So over the course, the longer you're on treatment, usually the better the side effects get, but that's not always across the board. So they can occur at any point in time, years down the road. The cracked skin around, there'll be pictures, but many of you have probably had it. It's always in the worst spot. Corner of the nails, corner of the toes, place that just keeps cracking open over and over. So trying to avoid using lotions that are fragranced, we want something that's alcohol-free. A lot of our patients have said that they swear by mane and tail lotion or the working hands lotion and just keeping everything moisturized. When the nails start to kind of peel and crack or lift off, then there's a couple of pretty strong, just plain old clear nail polish works for a lot of people, but there's some brand names that are a little bit thicker and seem to work better. So there's Genadur, which is a hydrosoluble nail lacquer, or polyurethane, or the brand name for that is Nuvail. And I think that one might be prescription. I'm not sure if that's over the counter. Some people swear by biotin. That's generally safe to use for skin, hair, and nails. The one thing to remember with that is if you're getting thyroid testing, then the biotin needs to be stopped because it can affect the TSH. So if you have a TSH that's out of range, they will often ask if you've been taking biotin, so that'll need to be held. And of course, keeping any area of skin breakage clean to prevent the infections that we just talked about from developing. If there's an open area of skin, the bacteria can get in there. So rash, again, depending on what the cause is, how severe it is, it may just be more of a cosmetic concern and not really bothersome. Some of them can be quite irritating and affect quality of life, which is, of course, what we're always trying to aim for is comfort, treatment, and are we affecting your quality of life in any way? For people who are really itchy, some people need a prescription medication called Atarax or something to actually help with the itching. Some of it's more of a nerve kind of itch, which is really hard to get to calm down because you can scratch and you just can never get quite to it. So sometimes that requires stronger medications for nerve pain, or some antidepressants actually work well for that. Or Benadryl, if that helps you, a Benadryl cream, or steroid creams. Hair changes, for some people, the hair thinning with the BTK inhibitors, or of course, bendamustine and Rituxan. Usually there's not full hair loss, but the hair thinning can be bothersome for a lot of people. So biotin, again, generally safe. The corkscrew texture, I don't know, there's really nothing to do about it. Just have it till you're off treatment. And then infections, of course, need to be treated with appropriate treatment, antibiotics, involving infectious disease if it's something severe enough that is kind of out of our league. So here's the typical ibrutinib or BTK inhibitor skin nails, the rash, the cracking fingernails, toenails. This is what we see. Fingernails for sure. Skin rash is not, we don't see it, I haven't seen it quite as much, but definitely a common side effect with that class of drugs. And then on the left-hand side there, A and B, is just more of one of the healing bullous lesions that we saw in one of the very first slides that can be kind of bothersome. So I mentioned that some people who get Rituxan can get psoriasis after that. It's not fully understood, but there is a component that it may be because of decreasing the immune system, kind of causes an autoimmune type reaction. Psoriasis has a pretty distinct look there in the picture, just a real dry, scaly, raised area. We generally, steroids. Once Rituxan stops, this usually gets better, but some people I have seen, Rituxan is completed after 6 months or the weekly for treatments, and then the psoriasis develops later and is persistent. So we would have, of course, with any of these things, if it's a persistent condition, making sure to see dermatology regularly, because some of these do require more treatment than just steroids or a topical cream. So just some final thoughts. Oh, and going back, I didn't have a slide on it, but skin cancer for WM is higher risk. So that can be melanoma and non-melanoma type skin cancers. So having a good dermatologist and getting at least a yearly exam, whether that's from treatment or just a weakened immune system, the risk of basal cell, squamous cell, and melanoma skin cancers is at higher risk for our WM patients. Always discussing side effects or concerns with your provider, and we're very blessed where we are in a lot of centers to have consultants right there next to us. So if there's anything that seems kind of out of the norm or something that doesn't seem like may or may not be related to WM, just bringing that up, always asking. I know that there's been a lot of conversation about advocating for yourself and questions to ask. And if that's your biggest concern in a visit is, oh, I have this skin lesion that may not seem like a big deal to other people, but if it's something that's really bothersome to you and that's the priority for that visit, absolutely bringing that up right away so that we can address that during the visit and not have it develop into something more severe as the months go on. And sometimes the skin rash, the lesion, whatever it may be, could require a treatment pause. And I know that's always a tough conversation when we're recommending to stop treatment for a period of time or to lower the dose because nobody wants their disease to progress. So that's always a conversation that we need to have in dialogue and a shared decision that the risks don't, that the benefits need to outweigh the risks. And if it's something that's risky to push forward with continuing treatment, then that's something that we definitely need to have a discussion about because the side effects, whether it's skin-related infection or anything else we've talked about the last couple of days, can be more severe as time goes on. So that may be the recommendation. Thank you, everybody, and I think we have time for questions if there are any. Yes? Oh, yes. Is there a connection between WM and varicose veins? I don't personally know of one. I know a lot of people have them. Is there high blood pressure associated with it or anything that's, no. Yeah, I don't know that there's a true connection or a cause and effect from that. Yeah, oh.
It should come on right now. Okay, along that same line, you didn't mention itching, and I know several of us have that issue. My itching is along my ankles, and it's always associated with varicose veins. Associated or not, I've never known.
Yeah. I mean, it's a lot of these things that the longer we go forward with the drugs and the treatments, and the more we learn from you guys. So and oftentimes when we start or stop a treatment and the symptom goes away, then we know that it was associated, but we don't always have the exact cause and effect.
Cyclovir can be prescribed as a prophylactic for shingles.
Mm-hmm.
Is there any rule of thumb of how long you should keep taking it? Is it forever or just for a period of time?
If you've had the shingles shot, technically the Shingrix, that should be preventative, although we have had several people who have had the shot and are on treatment and still develop shingles, so then they're on acyclovir or valacyclovir forever. Yes.
I saw that it said that dermatology, there's psoriasis post-Rituxan,
Mm-hmm.
and then another slide said that it may just be during Rituxan, but not after. And I'm a little confused, and I'm only asking because I've had these recurring patches that come out on my elbows, which I know is a key spot for psoriasis,
Mm-hmm.
which is also in my family genes. But I've never had problems before, but I'm having them now, and they seem to come every time I get a recurring yeast infection, which I know seems really weird, but it's always the same. It kind of heals and then will come back up again. Have you seen that? And I'm just curious how psoriasis relates to it.
I don't know for sure, other than it just inflammatory. So if there's just with the inflammation with the yeast infection and then having a flare of psoriasis, could be related. It sounds like one's triggering the other. As far as, you cut out a little bit at the beginning with your first part of the question about post-Rituxan. Yeah, it can be, if the psoriasis post-Rituxan and you're several months past, is that what you said? Or years? A year past. I don't know that it's well explained yet, whether it's over time. We know that Rituxan can deplete the B cells. So you can have the effects of some of this for quite some time after, even though you're not actively getting treated. The interesting thing for people with autoimmune or skin conditions, they can be treated with Rituxan. So I think that it's a little bit confusing, and I don't know that it's well understood to the effects, but we do see for some time post-Rituxan effects, even though you're not actively getting treated.
I think that was all the questions. I don't see anybody else. Oh, okay. There you go.
You said that melanoma is something that you need to be careful for. If you've already been diagnosed with melanoma, is it something that would indicate that you need to start treatment again?
For the melanoma specifically?
For
or
Waldenstrom's? If you have other indicators, but then all of a sudden you've been diagnosed with melanoma, should you also, is that a consideration to restart?
I don't think so, no. I think you're higher risk for melanoma and non-melanoma skin cancers, but I think having melanoma and being asymptomatic from your WM,
No.
no.
Not
If you're symptomatic from WM, then yes, starting treatment for that reason, but not because of the melanoma. Does that make sense?
Yes.
Okay.